everybody, we're back for another Compass to Care Reaching Rural America event, and this is Stuart Schlossman yes, I am Stuart Schlossman from MS Views and News, and we are back at our sound studio in Longwood, Florida, and we're doing these, we have the capability of doing these live programs from this place. We have a few fans. We have a few people in attendance out here tonight, and that's a great thing. All right, we have Jeff Siegel here tonight. He's a he's a MS exercise specialist, all right? And Jeff is going to be speaking first this evening. But I want to let you all know that we're doing a lot of these virtual events. Yes, you see me with a mask on because there are people around, and I just want to protect them from my droplets, all right? And we are trying to do as many virtual events as we can to benefit those in all of the United States, all right? Everybody from around the world that has multiple sclerosis can learn from these events. Yes, we're calling it a Reaching Rural America series, but the information can actually be used by anybody. But seriously, we do want those in rural America to be able to get benefit from these types of programs, which is why we do provide these. So with tonight's program, though, I just want everybody to understand and thank that we do have a sponsor. We have Novartis. Novartis is back in this series of programs beginning today, and then we will be doing other ones that they just sponsored. It'll be in, Chattanooga, Tennessee, Davis, California, and Dayton, Ohio, all right? Now, I'm just going to ask Jeff to stay to the side for a minute so I could just introduce Dr. Cramer. And Dr. Cramer is getting ready to speak with us. She's going to be speaking for about 45 minutes. For everybody that's got questions for Dr. Cramer, please type them in online, and I will be back by the desk in a little bit. Okay, I will be able to take those, but we are not going to interrupt her for 45 minutes. She's going to speak, and then we will do a lengthy Q&A because we have 6 pages of questions already for the doctor. So let me first introduce Dr. Cramer. Dr. Cramer is a graduate of Georgetown University School of Medicine and the University of Colorado Health Sciences residency in neurology. She's worked as a general neurologist in Colorado for 3 years and then moved back home to the East Coast. Dr. Cramer's longtime goal had been to start an MS center in the Roanoke area. In 2019, Dr. Cramer achieved that goal with the opening of the Roanoke Area MS Center and continues to grow with the mission to bring resources to her area for multiple sclerosis patients and their caregivers. Let's now welcome Dr. Cramer.
Thank you so much, Stuart. I'm really excited to be doing this program tonight and talking to all of you, and I'm dying to hear what the questions are. But let's go ahead and take a look at a couple of topic areas. We live in a rural area in Southwest Virginia. It is close to a couple of college towns, but between the Roanoke area and all of the surrounding college towns, there are about 500,000 people spread over 1,000+ mile radius. It's just a tremendously beautiful area, but we tend to not be real urban, so we don't have as many resources. And I want to speak a little bit to, well, what do you do if you live in an area that doesn't have good Wi-Fi signal or doesn't have a lot of resources? How do you handle that? How do you navigate that kind of location? I'll tell you what we do is we really have groups that we use. We rely on one another. We ask the National MS Society for our resources. We can use public Wi-Fi at libraries. If you buy a cup of coffee at Starbucks, you have public Wi-Fi there as well. Some groups have grown up in our areas so that we can share resources. So if one person doesn't need a wheelchair anymore and another person does need a wheelchair, in our area, we have our support group manages those resources, which has been tremendous. Talk with your doctor. Find out if your physician knows how to get things done through the Multiple Sclerosis Alliance or through the National MS Society. So for example, the MSAA sponsors a scholarship where they will pay for an MRI. They used to have a program where they could do a brain and a cervical spine MRI. It's now a brain MRI every 2 years, and this is for people that just cannot afford their MRI. How about getting access to medications? Again, talk with your doctor. There are sometimes programs and ways that we can get resources even if you don't live in a rural area, that you can access these resources. It's really our goal, those of us who treat folks with multiple sclerosis, to try to eliminate as many barriers to care as possible, and we understand there are a lot. What are the different types of MS? Go ahead and go back for just 1 second, please, Bill, and I'll give you an overview here. The different types of multiple sclerosis are clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, what is now called secondary active secondary progressive MS, or secondary progressive MS with relapses, and primary progressive MS. So some examples of these might be in clinically isolated syndrome. A person might have had one clinical event and maybe not enough markers on their MRI or enough abnormality in the spinal fluid to accurately predict this is going on to become multiple sclerosis. So it's just one event, and that's early on usually in the course of multiple sclerosis, but not everybody with clinically isolated syndrome goes on to develop full-blown multiple sclerosis. Relapsing remitting MS is the most common form of MS. About 85% of people with MS, at least in the beginning of the disease for the first 10, 15, 20 years, have relapses. And these are sudden spikes in neurological problems, new flares, new neurological deficits, new symptoms. And between those relapses, the person may plateau or may progress. And this is where we get secondary progressive MS. So after a period of relapsing, usually about 15, 20 years later, about 50% of people initially with relapsing MS will go on to develop secondary progressive MS. And we think what this is the accumulated damage to the nerves themselves. There's less inflammation, so there's less of the spike in the symptoms, but more of the accumulated damage over the years causes gradually worsening, often of old symptoms that people have had. Secondary progressive MS can be considered active MS if there are relapses happening as well. So between relapses, the person may continue to accumulate damage, accumulate neurological symptoms, and we call that active secondary progressive MS. Primary progressive MS is a rarer form of multiple sclerosis, approximately 10 to 15% of patients who never really have relapses and have a progressive course of accumulating damage and neurological symptoms right from the beginning of their disease. Often can be either cognitive or gait problems that just start and get worse and worse and worse, even though there wasn't a sudden onset. There aren't relapses. To be more specific, in relapsing multiple sclerosis, there are relapses. Some people call them exacerbations or flares. New lesions will develop, new symptoms happen. These are sudden attacks. Sometimes these attacks can be confused with strokes. So they're that fast. The person will go to sleep feeling fine and then wake up the next morning unable to use half of their body, cannot see out of the left eye. A relapse is defined in the medical literature and in the clinical literature, so in research and also in the clinical setting, as any new or recurrent impairment that lasts for more than 24 hours. Most people have 3 or fewer relapses in a year, but some people can have more. Mild relapses might be considered something that doesn't necessarily interfere with your function. So a little numbness in your non-dominant hand that doesn't keep you from using it might be a mild relapse. Moderate might be disabling enough to need treatment or to get in your way, keep you from doing something. So for example, loss of grip strength in your dominant hand that you can work around but is very difficult. Severe would be considered, a severe relapse would be considered that relapse which makes the person unable to care for themselves, requiring major assistance, unable to walk, cannot void their bowels or bladder. Obviously, mild, moderate, and severe could mean different things to different people. So many years ago, I had a patient with a relapse that involved some loss of dexterity in the non-dominant hand, which probably for most of us would just make it harder to type, or we might have more trouble putting on buttons. But this person, as a living, was a concert violinist. And this was a problem. This really got in her way and required treatment. So while most of us might consider that fairly mild, it was really quite interfering and moderate to severe for her. It's fairly rare that a relapse would be life-threatening, but if it's in the right location, you could have blockage of breathing, you could have trouble swallowing, you could have difficulty with your stomach and GI functions that would become life-threatening. And fortunately, again, that is rare that an exacerbation would be life-threatening. Secondary progressive MS involves gradual worsening, usually of symptoms that you've had before. So if you've had trouble with the right leg, this gets worse and worse, more spasticity, more trouble with the balance and the walking. Progressive MS can move either very quickly, where a person progresses in a matter of months, or very slowly, where every 5 years or so things get worse. Some people have periods of progression that are more quick, and then they plateau, and then they accelerate and have more symptoms again. The definition that most physicians use when they're evaluating whether somebody has progressive MS is, has the person had a year of progressive symptoms that both the person can appreciate and the physician can appreciate, but no changes in the lesions. So if there's a progressive phase, and this is part of why we think that the progressive phase of multiple sclerosis is an axon problem or a dying out of the nerves, or the person has lost their neurological reserve, is that the lesions will not change in secondary progressive MS. In active secondary progressive MS, yeah, the next slide. Perfect. In active progressive MS or active secondary progressive MS, there are new lesions, there are relapses, but the person continues to progress also. So we almost have two overlapping phases of the disease. There's the inflammatory phase where the person is relapsing, but then there's the axonal exhaustion and the neuronal dieback phase, which is the progressive phase. The term active progressive MS is sometimes really confusing because I think a lot of patients and physicians think, well, active progressive means that it's getting worse, it's actively worsening. The active part means that there are relapses or new lesions. And so make sure that you understand that, because progressive MS can be getting worse, but if there are no new lesions and no new exacerbations, it's not considered active progressive MS. Active is where there are relapses and new lesions. Primary progressive MS is right from the beginning of the disease. There's progression in the symptoms. There's no real exacerbation. Nothing suddenly happens. There are no new lesions in most people, although in some folks with primary progressive MS, we can see accumulation of new lesions. What is rather frustrating for all of us, physicians and patients with primary progressive MS, is that it's different medications that work for primary progressive MS than work for active secondary progressive or relapsing remitting MS. So most of the medications that are out as disease-modifying therapies are out to prevent the relapses, to prevent the inflammation, to prevent the new lesions. But those medications, we've learned, just do not work very well to slow down primary progressive MS. And in fact, it wasn't until Ocrevus came to the market a couple of years ago that we even had a strong, safe option for primary progressive MS. Prior to that, some of us had used Nobantrone, but it had its own problems in that it caused heart damage, it decreased how well the heart would pump, and could increase the risk of cancers down the road. So very different medications that we use to treat primary progressive versus relapsing forms of MS. So regardless of the type or the phase of multiple sclerosis that you have, there are some resources to add into your regimen complementary therapies and wellness ideas in MS. And we just heard some great options for exercise and maximizing the function that you have. None of us are getting any younger. And with the MS, it's even more challenging to keep balance, to keep strength, to use the body in a way that's healthy for the body so that it can work properly. Complementary therapies are generally defined as adjunct or add-on therapies. Most of the complementary options that we have really haven't been studied by themselves as a standalone. So they really should be used with standard disease-modifying therapies, which have been proven to substantially slow down the disease. For example, some of the complementary therapies that folks will use and have been found in research to be helpful are getting vitamin D levels up over 50 in the blood. So D3 is usually the supplement that people will take, sometimes D2. We actually measure in the body vitamin D in its 25-hydroxy form. And if that level is over 50, that seems to protect the nervous system. And it protects the nervous system not just in multiple sclerosis, but has also been shown to decrease the risk of other diseases like Parkinson's and slow down Alzheimer's, improve memory in older, healthy adults. So getting that vitamin D level over 50 is really key. How high is too high? Well, I tell my patients over 75 and you're just wasting your money with those D supplements. We don't really know how high we can safely get the vitamin D levels, but we do know that in animal models, if we go over 200, that's way too high. That makes the animals sick. And probably in people, if we go over 95, we might get into some toxicity issues. Although most people tolerate it well, your body breaks it down. There's really no good scientific reason to get that level much above 50 to 75. So that's the range that I usually give for my patients to use. Acupuncture has actually been studied in multiple sclerosis. If you're not familiar with acupuncture, it is a very small needle, looks like a teeny tiny hair. It's a solid needle, so it's very, very small, very thin, and it's inserted just underneath the skin in strategic locations around the body, depending on your symptoms. And a well-trained acupuncturist will know exactly where to put them. Then the needles are left in place for different periods of time, and then they're removed. Acupuncture has been shown to reduce spasticity, anxiety, pain. Unfortunately, it may worsen weakness. So as you relax that spasticity, relax those muscles, you can get more weakness. And some people report more fatigue after acupuncture, although that's fairly unusual. CBD oil or cannabinoid oil, hemp-based, that contains the CBD, but not the neurologically psychoactive THC component, helps with spasticity and pain, usually in fairly high milligram strengths, but it can worsen fatigue. It can also worsen cognition. So anytime you have a substance that may help one thing, keep in mind it may hurt another thing too. And just like when we're using standard therapies or pharmaceutical medications, remember anything that you take on as a complementary therapy can have its upsides and its downsides. So make sure that you balance that out in your particular situation. Some data from several years ago showed that very high dose biotin supplements might reduce relapses. However, it also might worsen diabetes and block statin medications. These are the medicines that are used to help with cholesterol, and it can have some interactions with other medications. So before you take any really high dose supplement, make sure you talk with your doctor. A lot of us are fairly well versed in what side effects there are, what benefits there are, and we can talk with you about the pros and cons of different interventions. Wellness in MS is very important. The body is more resilient when it's healthy. It manages relapses better. It can compensate for neurological damage better when it's healthy. How do we keep our bodies healthy? Well, some of these are easier and some of these are harder. Adequate sleep. Oh my goodness, how many of us actually get adequate sleep, right? So if you're sleeping well, you'll be less fatigued and your cognition will improve. I talk with people all the time that tell me, Dr. Cramer, I can't think straight. Some of these people don't even have MS, and we go into their sleep habits and they're getting maybe 2-3 hours of sleep at a time. I know I can't function on very little sleep. We proved that when I was in residency. And anybody who's really sleep deprived, if tests are done looking at their cognitive powers, they're not really powerful cognitive powers when the person hasn't slept. Get them some good sleep on a consistent basis. So you can't sleep badly for a week, have one good night's sleep, and then everything's good. No, you got to get in that good sleep. Well, how many hours are appropriate? Everybody's a little different. Some people can get away with 6 hours. Some people need 10 hours. I always used to like to joke that Einstein actually used to say he needed 10 hours of sleep to function. And I figured that any of us who need a lot of sleep to function, we're just in good company with Einstein, right? It's just because we're so smart, we have to power these brains. But most people, most adults, 7 to 8 hours of sleep at night is really preferred. And at least 4 or 5 of those should be consistent, consolidated hours. I know that's not always easy. Spasticity gets in the way, bladders get in the way, the cat gets in the way, the dog scratching on the door gets in the way. Whatever you can do to get a quiet, calm environment, a consistent pre-bed routine, a consistent wake-up time, this gets you in the habit of sleeping properly and doing the best that you can with your sleep. Exercise. So whatever you can do. I hear the exact same question that was just answered a little bit ago. Well, Dr. Cramer, what if I can't do this, this, and this? I'm not asking you to go out and run a marathon if you can't run a marathon, but your body is made to move and it's made to exercise and stretch, and bodies don't work well if they're not exercised. In fact, exercise helps pain, it helps spasticity, it helps cognition, it helps fatigue, it helps mood. It helps to grease up your joints so they don't hurt as much from arthritis. It's good for your heart. It's good for your lungs. Reduces the risk of cancer. It decreases the chances of Alzheimer's. So exercise is really, really important. And it's whatever you can do. Massage. Getting a good, deep, relaxing massage is good for pain and particularly good for spasticity. And one of the things I like about massage for spasticity is it doesn't have a lot of those side effects like some of our medications do. We're not getting into dry mouth and excessive sleepiness. It really helps to work out and loosen those too tight muscles so that the body can function more appropriately. A balanced diet is really important. So what is a balanced diet? Well, a balanced diet means that you're eating a variety of foods. You're avoiding processed foods. So sorry about this. Restaurants, fast food, anything in a box, processed stuff. Not really good for your body. You're bringing in a lot of chemicals and additives that aren't healthy, that aren't part of the original plant or the original animal. You really want to decrease your red meat intake to only 2 times a week and increase fish, increase green leafy vegetables. Green leafy vegetables, olive oil, and fish are incredibly healthy for the heart, the muscles, and the nervous system. And really eating foods that are as close to nature as possible. So eating a salad with very little salad dressing, for example. Using fish that hasn't been marinated in a lot of extra flavorings. Just maybe use some spices on the fish. My family likes little dill sprinkled on it and some salt and pepper. So there are some different ways that you can kind of spice up the food, but you'll feel less hungry. You'll feel more satisfied. You'll feel less tired eating properly. And your body will have the building blocks that it needs to keep the nervous system healthy and also to keep your cardiovascular, your lung, your liver, your kidney, your whole body will be healthier with a consistent, healthy diet. So how to access the care for multiple sclerosis? I went into some of these ideas a little bit earlier when I was talking about being in a rural area. So the first person is in your care team with multiple sclerosis, you really need a neurologist. A neurologist is a physician who is specialty trained in diagnosing and managing nervous system conditions. Just so you get the idea of the training that we have been through, after a neurologist has completed undergraduate studies, which usually, but not always, are in biology or something scientific, we have basic requirements for certain science classes. We then pass an entrance examination test called the Medical College Admission Test, MCAT. And based on MCAT scores and a lot of other factors like our grades in undergrad, our extracurricular activities, we then would go to medical school, 4 years of medical school. Medical school involves 2 years of classroom teaching, learning about the theories and the science behind how the body works, physiology, anatomy, gross anatomy, dissecting cadavers, learning how to interview patients, microbiology. We get a good basic general background in these areas, as well as pharmacology and pathology. Then after the first 2 years of medical school, we all spend another 2 years in medical school practicing our craft. So applying what we've learned in medical school and going onto the wards, going out into the office and working with physicians who are closely supervising us, and we are hands-on with the patients, taking a history, doing exams, and learning how the tests work, how to interpret the tests. After 4 years of medical school, a physician who has graduated still cannot be licensed in the United States to practice medicine. After the first year of residency, called an internship in most residencies, then that person can take the first of their licensing exam. And if they pass that round of the licensing exam, they take the third. They've taken the first 2 in the first parts of medical school. After their intern year, they can take their licensing exam. And after they take the licensing exam, then they can practice as a general physician. Now, most physicians don't do that. They don't exercise that option. Most physicians go into a residency, and in a neurologist's case, we do 1 year of internal medicine that teaches us about, diabetes, and we work in the intensive care unit and in the emergency department, and we do a lot of internal medicine for 1 year, and then 3 more years of just practicing neurology on the wards in the hospital, in the outpatient clinic. So by the time a neurologist has completed training, that's 4 years of undergraduate, followed by 4 years of medical school, followed by 4 years of residency. Or like I like to say, I did 25 straight years of school from kindergarten to the end. So a lot of training goes into that physician who's been specially trained to diagnose and manage neurological conditions. Your neurologist may or may not be an MS specialist. So for example, I am a general neurologist with an interest in multiple sclerosis, but I do not have a fellowship training. All of my training has been through courses and classes that I have taken and working with patients. This person is really key in your care team. The next people who might be involved in your care might be other specialists. So if you have urinary issues, you might see a urologist. If you have constipation, diarrhea, bowel problems, you might see a gastroenterologist. If you're having a lot of difficulty with mobility and you need braces or somebody to help guide therapy, now some neurologists can do that, but we also may call in a rehabilitation specialist called a physiatrist. Other people need other specialties depending on their symptoms. These are the most common that I see patients really needing in my practice. Primary care physician is very important as well. So a primary care physician is specialty trained to diagnose and manage general medical conditions. So I went through the training for a neurologist. After medical school, a primary care physician does another 3 years of residency that helps them to learn how to manage diabetes and common medical illnesses and constipation and some urinary problems and weakness and blood pressure and those kinds of things. It's really important to manage overall health along with your multiple sclerosis. We all have health concerns. We all want to stay healthy, and staying healthy really is important. The primary care physician can help ensure that you're staying healthy, because we don't want you developing new problems while we're focusing on the multiple sclerosis and maybe didn't notice diabetes because we're not checking your blood sugars, or the blood pressure is sneaking up and needs to be managed. That's where the primary care physician really comes into play and is a very key person in everybody's care team. How about community and online resources? Well, I've listed for you here a couple of the MS resources, like the National MS Society.org, MS Alliance of Virginia.org. That's one that's local to me. Your local MS group may be an excellent resource for you. The MSAA.com, that's where you can get your MRIs covered if you're not able to pay for them. And then, of course, there's MSviewsandnews.org. So those are all really important resources that we can all use and plug into to get our information. Like I mentioned before, if you don't have access to the internet, library computers. A little harder in the age of COVID. Some libraries aren't letting people sit in front of the computers, but there are public hotspots. Starbucks has a hotspot. Some other restaurants have hotspots. Making phone calls, very important. Tap into your resources. Tap into your overall support group. Call people. Do Zoom meetings with folks. Our local one, the MSAV, we have an office right near us where the MSAV has all of their resources in one place. So if you need to find out, who's a good disability lawyer in our area, you come in and visit the Multiple Sclerosis Alliance of Virginia. Your area may have a national MS chapter. You may have another local support group. These are excellent resources because they're patients who know what the resources are in the area and have gathered together to make sure that those resources are available. So what about COVID-19 and multiple sclerosis? I get this a lot in my office. What's the latest? What's going on? What do we know? Where are we going? How long is this going to last? Can we take our stinking masks off? I'm happy to not have to be wearing my mask for the first time all day long because nobody else is around me. I'm here by myself in my home office. When I'm at work, I wear my mask the whole time. So I get it. I'm right there with you. It's getting a little tiresome. So where are we with this process? First of all, a question that I get a lot is, I have MS. Am I at higher risk if I catch COVID? And I have some super good news for you. No. Outcomes for people with MS are really similar to outcomes for people who don't have MS. So the MS alone does not seem to make people at higher risk with COVID. Certain medications, but not all of them, certain medications that are used to treat MS may increase your risk of contracting the virus or your ability to combat the virus if you're on those medications. So especially medications that really dampen your whole immune system. People on Ocrevus, though, who have contracted COVID, Genentech has kept a database, and that database shows that people on Ocrevus who get COVID have a very similar pattern of outcomes to people who are not on Ocrevus. So what does that look like? About 2% of people have died. About 15% of people have been sick enough to be in the hospital. And about 85% of people have had varying degrees of symptoms, but have not required hospitalization. So that's the good news. Getting COVID on Ocrevus doesn't necessarily mean you're going to have a worse outcome than if you hadn't been on Ocrevus. How about some of the other disease-modifying therapies? What about Lemtrada or Gilenya, Mayzent, Zeposia? Some of these medications actually increase your risk of catching viruses. There's mixed data on Mavenclad. Some research shows that folks who've gotten COVID on Mavenclad don't necessarily have poor outcomes, but there is a time of after a person takes Mavenclad for 6 to 9 months where the immune system is really depressed. Could that be a time when they're more susceptible because they're more susceptible to other viruses as well, and that's possible. Some medicines actually have antiviral properties, beta-seron, Avonex, Plegridy, Rebif. So the antiviral property comes from the interferon portion of these medications. So kind of mixed. The MS alone does not increase your risk, but you might want to talk about your medication with your physician and your care team to see what do we know. We are getting updated information on a pretty regular basis. And for the most part, at first, I actually delayed some of the treatments, worrying that this would get people more sick. But now we're not delaying treatments. We're not avoiding starting medications because of COVID. We're just asking people to wear your mask, wash your hands, and those kinds of things. So just for some information, there's been some data about coronavirus in people who have MS and people who should maybe be a little bit more cautious in general are people with progressive MS, people who are over the age of 60. Now that's across the board. Folks who are over 60 are much more likely to die from COVID than people 60. That's a real defining line. People who have more disability. So you know when you get sick that can really cause a lot of symptoms. And COVID's no exception. If you get COVID, you could have a lot more MS symptoms. And if you're already quite debilitated, that could be a real problem. People with diseases of the heart or lungs, and again, that's in general, not just MS patients need to be more careful and take more precautions because they're at higher risk. And people who have a body mass index of 30 or higher, very consistently, we are finding that that alone increases the chances of a poor outcome or a more dangerous course of multiple sclerosis. I said multiple sclerosis, I meant COVID. Sorry about that. All right, question I get a lot. Isn't COVID just like the flu? No, guys, it's not just like the flu. The fatality rate is approximately 2 to 3%. The seasonal flu is almost always less than 1%. In addition, COVID is not seasonal. It did not go away once we got into warmer weather. It was not less impactful in Florida than it was in northern climates. It is more infectious than the flu. It's easier to catch it, and that's probably at least partially because people are infectious in the day or two before they have any symptoms of COVID in many cases. It's estimated that about half of people never have any outward symptoms of COVID and could be out in the community and spreading it. And people could be spreading it the day before they wake up terribly, terribly sick with COVID, but they've already come into contact with people. That's a little different than the flu. People usually feel pretty bad when they have the flu and when they're infectious, and it's a much faster onset. So there aren't days before a person gets real sick with the flu when they're out and about and doing their usual things. The flu normally lays people down too. So if you've ever had the flu, it's horrible. Anybody who's on a medication, one of the interferons, you know what the flu feels like because that shot, that interferon shot, is what your body makes to fight the flu, and it's why you feel so bad when you have the flu. So you get these high levels of interferon trying to fight the flu, and you feel horrible. So you're not casually going to the grocery store when you have a light case of the flu. That's just a lot less likely to happen. And yet a lot of people with COVID have gone to work, weddings, funerals, gone to the grocery store, have flown internationally. And so we know that COVID cases have come from those scenarios where people had minimal or no symptoms and were out, unfortunately, they didn't even know we're spreading COVID. We cannot predict fully who is vulnerable. We know the age, we know the body mass index over 30, we know people who have other health issues are more at risk, But there have been healthy people that we would not have predicted that would have died from COVID who have died from COVID. So there are other factors, or maybe there are invisible factors that people don't necessarily know that they're struggling with. Even in the people who have recovered, and this is really different than the flu. The last time I had the flu was about 3 years ago. And when I had the flu, I was out for 5 days. I could not move, pick up my head. I just ached all over. I had fevers. It was awful. I felt like I was going to throw up every time. I know, too much information. I'll stop there. But when you're over the flu, in that case, it took about 2 weeks for me to feel normal. But after 2 weeks, I was breathing normally. I was moving normally. My brains were working properly. A very high percentage, estimated between 40 and 60% of people looking at countries where COVID hit early, like in Italy and Spain, going back and talking with people who've had COVID, about 40 to 60%, even now, 4 to 6 months later, they're not okay. They're still short of breath. They're still exhausted. They still have body aches and pains. They still can't think straight. Kind of like having MS all the time. So to throw COVID on top, this isn't an infection that comes in, does its thing, moves on out, and no big deal. This is not the common cold, and this is not the flu. It sticks around in a good number of people. Should I get a flu shot? Well, yes, you should get a flu shot. And the reason you should get a flu shot is there is research that shows that you are better off getting the flu shot than getting the flu. Some data, preliminary data, so we haven't really sorted this out yet, indicates that maybe that flu shot boosts your immune system to help fight COVID. It's not a money-back guarantee. We're not sure about that, but it looks like that same kind of process, even though it's against the flu, your immune system kind of revs up and it might help you to fight COVID. There are some considerations for medications. If you are on Ocrevus, Lemtrada, or Mavenclad, you want to take your flu shot 2 or more weeks before those medications. Now, if you take it after the medicine, you want to take it as long after the medication course as you can, because the flu shot's more likely to work. The problem with Ocrevus, Lemtrada, Mavenclad is they really knock out your ability to make the B cell response to the flu shot. And so it's not as strong of a response and your body doesn't respond to it as well. So there's a little strategy in planning around these medications. With other disease modifying therapies and ofatumumab, Kesimpta just came out. It's very similar to Ocrevus. You have that same kind of short window, but Kesimpta is given once a month. So you would want to get your flu shot in that last week, right about a week before you take the shot to get the biggest boost out of the flu shot. With other therapies, Gilenya, Mayzent, interferons, Copaxone, you can get the flu shot at any time. You don't have to strategize your exact timing. But Dr. Cramer, I am so tired of wearing a mask. I hear you. So am I. So am I. I spent most of medical school and residency wearing masks because I was in and out of operating rooms and really sick people's rooms. And I always felt freer when I could take my mask off. And now it's, the first thing I do when I leave the office and I'm outside and by myself and I can't breathe on anybody else, get this mask off from me. I get it. There's been a lot of really confusing, conflicting data in the news about masks. But I have to tell you, the medical data on masks is not confusing at all. Medically, what the mask does is it prevents the virus from being carried on droplets into the air. Yes, the virus can be blown by itself, but the way respiratory viruses spread the most efficiently is on droplets. So if I'm wearing a mask, I can't spray my droplets. If I cough, those droplets stay right next to my mouth and won't get sprayed onto somebody else. If I'm wearing a mask and I'm sick and you wear a mask and you're healthy and we stay 6 feet apart, there is virtually, not completely, but almost no chance that you could catch the virus from me. If I wear a mask and you don't wear a mask, your risk is elevated a little bit. If you wear a mask and I take my mask off and I'm sick, maybe I don't even know it, that actually increases your risk quite a bit. So my advice is, yes, wear your mask, but also stay 6 feet or more away from people who are not wearing a mask, because they might be sick and not even know it. So many people, about 40 to 60% of people, like I said, are asymptomatic when they're out and about and can be spreading the virus. 6 feet is an awkward distance. You don't have a conversation from 6 feet away. It's really the most comfortable to talk to somebody about 3 feet away from you. So be aware of that. If you've gone to a social event and you're around people you know, you have to work at it pretty hard. You're not going to automatically sit or talk or want to be 6 feet apart. We see a decrease in cases and deaths where people are wearing masks. And we think but part of that is because people aren't as exposed to this virus. It's not being sprayed through the air where somebody else can breathe it in. But also, it decreases how much virus a person breathes in. So if they get a smaller load of the virus, they're less likely to get as sick. It's also important to wear your mask properly. So the first important thing to do is make sure that the mask is up and over your nose. I wear glasses. My glasses are fogged up half the time. I get it. It's really super duper annoying. If the mask is fitted, and a lot of them have a metal piece in them, if they're fitted across the top of your nose, you're a lot less likely to fog your glasses. The second thing you want to do is pinch your nose and take the front of that mask and bring it down underneath your chin, because that makes a pocket right over your mouth where you can actually breathe. It's pretty annoying when that mask gets right up on your mouth, isn't it? So keeping it away from your mouth is really important, and it should securely fit over your entire face. Putting it down below your mouth does not help at all, because now you're breathing it out. Putting it below your nose doesn't help at all, because where does the virus like to go? The back of your nose. So whatever you're breathing, they're just water vapor droplets carrying that virus around. And try not to have loose gaps. The fewer loose gaps, the less likelihood there is for virus particles and for any spray to move around the mask or get into you. I miss my friends too. I really do. I am a people person. I like being around my friends. I like going to lunch with my friends. I like going to dinner with my friends. I like visiting my friends on the weekend. I like to hug my mom. I like to visit my nephews. I am so with you. This social isolation it's hard. It is really hard. But dying in an ICU on a ventilator is really hard too. So maybe your risk is kind of small because you're in an area that doesn't have a lot of COVID, but the consequences can be so severe. And that's why medical professionals are saying, let's just try to do the best that we can to mitigate this virus. Wear your mask and stay in small groups, because if you're in a small group, there's a lot less chance that any one person would be infected. Let me give you an example. In one area I was reading about recently, you could estimate that the current number of active cases was about 1 in 100 people. Okay, so if you're in a group of 100 people, statistically, there's a chance that one person is carrying the virus. And if that person is near 5 or 6 other people who are around 5 or 6 other people, it can spread pretty quickly. In fact, there was a wedding in Roanoke, Maine, a couple of weeks ago, beginning of July. 85 people attended this wedding. One person at the wedding was sick and infected people at the wedding, who went to work and infected people at work and home, and those people went on to infect other people. There have been over 135 cases of COVID directly related to that one wedding, and 7 people have died at this point from that one wedding. That gives you an idea of how quickly this can spread. On the other hand, if you keep small groups and wearing masks, if you have a 1 in 100 chance that anybody in the room has COVID and there are only 5 people, pretty good chance that none of them have COVID. But the problem is we can't accurately know. Even the nasopharyngeal swabs have about a 30% false negative rate. That means that that person could have COVID, but there isn't enough COVID in the nose, or the COVID has actually moved from the nose down at that point, and so it can't be tested. Or we're testing at the wrong time. So if a person just got exposed yesterday, we know that there's a buildup phase of the virus, so that the test isn't really accurate until about 5 days after a person was exposed and up to about 8 days. So if you do the test at day 2, it's a whole lot more likely to be negative, even though the person is infected. And if you do the test at day 11 or 12, it's a whole lot more likely to be negative, because the person has already cleared the virus and it's gone on and is doing its damage somewhere else. If you do attend a small group, wear your mask, just like we discussed. Make sure everybody else is wearing masks. Outdoors, 6 feet apart, wearing masks, 5 people, 10 people, pretty low risk. If you go to one group activity, really try to avoid going to another group activity within 2 weeks. Why do I say that? Well, because 2 weeks is how long it takes for the virus to really run its course in a person, from the time of exposure to the time where that person is no longer infectious. So if you go and spend time with, a small family gathering, and then 3 days later go and visit with your friends at the library, and then a week later go to another small group with some friends at their home, you haven't just spent time with 10 people. Now you've spent time with 10 people in each location. You've spent time with 30 people. And if you picked it up at the first place, now you're carrying it to everybody else. So these are the kinds of considerations just to try to slow down the spread of this virus. I'm hoping that the more we spread it, the more we're going to be able to get back to normal activities, because the caseloads will drop, the hospitals will be able to handle the cases, and there will be fewer deaths overall. So how do we meet with our friends? I do a lot of phone calls to my friends. We do Zoom meetings. I have some friends that do a Zoom Bible study. So on Monday nights, we all log in and we do our Bible study together. And some people are doing arts and crafts together, and knitting and crochet, or Bible studies. Some people have picked up the old-fashioned art of writing a letter and just jotting down a letter to other people. We're very connected. This is a time in the world where we're very, very connected. We don't live 100 years ago where we might have limited phone access, or it might take days to get by car to go see somebody. So reaching out to people in other ways, not just seeing them. But I agree with everybody who says, I don't like masks and I miss my friends. Me too. I am right there with you. And believe me, if I thought that it were safe medically for us to go out without masks and do our thing, I would tell you that. But, I see a lot of people that don't have very good immune systems and are over the age of 60 and have BMIs over 30. I can't afford to get sick and get them sick, and you can't afford to be sick either. So that's my advice on COVID. So just to go over it one more time. Okay, what are the rules again? If you're around anyone who doesn't live in your household, stay 6 or more feet away, stay outdoors, wear masks, and avoid being within 6 feet of people who are not wearing masks, and don't spend more than 10 minutes with that person. So the absolute safest bet is no in-person contact with anyone outside of your household. So you don't have somebody coming into your house doing construction or cleaning and not wearing a mask. That would be in-person contact with anyone outside of your household. Safer, you keep 3, but not 4 of the rules. So let's say you're going to be inside, but you're only going to be there for 5 minutes, and you're going to wear a mask, and you're going to stay 6 feet away from people. Okay, that's safer. We don't know the percentages of how safe that is. We just know that that's safer than if you break 2 rules. So relatively safe still. Go to the grocery store. You're going to be in there for more than 10 minutes. It's inside, but you're going to wear a mask, and you're going to stay 6 or 4 more feet away from people, and you're not going to be 10 minutes with one person. Pretty safe. Risky, you're breaking 3 rules at a time. So you're outdoors, but you're within 6 feet, nobody's wearing a mask, and it's a family function, you're going to be there all day. There have been examples of family barbecues and birthday parties where people were outdoors eating together, and entire families got sick and people died. So this is pretty risky social behavior. The riskiest is breaking all 4 rules. And again, if you're lucky and nobody around you has COVID, you might get away with it. But what if somebody does have COVID and you can't get away with it? Again, the consequences can be quite dire. Of the people who get COVID, again, 2 to 3% are dying from COVID. Not everybody's going to get COVID, but the people who do can be very sick. And even the people who recover, 40 to 60% still have symptoms months later. Fatigue, shortness of breath, just not happy members of society, unfortunately. So the more of these rules or principles, I guess would be a better word for it, that you keep, the safer you are from COVID. So again, outcomes in MS, fairly consistent with the general population. Most patients do not need to be hospitalized, even though they're on disease-modifying therapies. Very, very similar to the general population in terms of how risky it is to get COVID. And DMT use did not come out as a real predictor of poor outcome in a small sample of patients with MS at the New York Multiple Sclerosis Center. There have been 692 confirmed patients with MS who've gotten COVID. Over 80% are recovering, and the death rate has been 5.8%. Over half of them had other medical problems, but let's be honest, most of us have other medical problems, right? Of the number of people, of the cases, 46.9% had high blood pressure, obesity were the most common, or other comorbidities. But the comorbidities, you don't have to be super sick. I mean, you can have well-controlled hypertension. That's a comorbidity. You can be a little fluffy, otherwise perfectly healthy, comorbidity. You may be over 60, fit, trim, no high blood pressure, you eat your fish. So over 60 is a comorbidity. So they're not comorbidities in the sense that you're sick. These are healthy people that happen to have other medical problems, and that's all it takes for COVID to turn really into something dangerous. Now we will go on to some questions. I know that Stuart's been hanging on to questions for me, and I'm looking forward to hearing what you all need to know.
Can you hear me now?
Yes.
Great. Awesome. So I was thanking you for doing this program, and I learned that this microphone has a separate mute than the mute that was on the computer. Okay. So anyway, learn something new every day, right? As long as we all learn, we're in great shape. That's why people are here. So let's go on to the questions now. But again, I do want to thank you for speaking tonight. I'm very delighted. I'm sure that many people will do very well from hearing your discussions, and I'm sure that those in rural America will appreciate it as well. So the first one is, should everybody be on a medication for multiple sclerosis regardless of their age?
No. So the decision to be on a disease-modifying therapy or not is a very individual decision. In general, younger people have more inflammation. Their bodies are more robust with their inflammatory response. And in general, younger people, people under the age of 60, tend to have more relapses than people who are over 60. But some people in their 70s continue to have relapses. So there's no age at which we say everybody should be on medicine or not be on medicine. It has to do with more how active your disease is, how clean your MRIs have been, and your age. There are a lot of different factors.
Okay, thank you. For everybody that's watching, if you have questions to ask, please type them in online. We do have several, and of course, we do have 6 pages in front of me as well. But we're going to try to get to every single one of them. Some are similar to others, so I may combine them as well. Okay, next, how do I stay active with so much fatigue?
That is really difficult, right? So what you really want to do is find some activity level that you can pull off every day and make sure you do that every day. And it might just be a short walk, and it might be going to the mailbox and back, but make sure you do that every day because you're trying to maintain your stamina. And yes, some days are going to be harder than others. That's how MS-related fatigue works. But you want to keep up that activity. And when that activity becomes second nature, you can do it very, very easily, then you can go on and add something else. So, you know, go halfway to the mailbox and back, and then go to the mailbox and back. So trying to build that stamina. The fatigue is very, very difficult, and I do understand that. The idea isn't to exercise to the point where you have to pay for it for 3 days. The idea is to find something that you can do every day and keep it up.
Great, thank you. If you have SPMS and the MRI shows no new lesions and no active lesions, but weakness gets worse, what would this indicate?
So if the person has progression of symptoms and no new lesions over 1 year or longer that the patient can appreciate and the physician document, that is secondary progressive MS, and it indicates that either the person has gone from an inflammatory phase into just secondary progressive MS, or if the person is on a disease-modifying therapy, that disease-modifying therapy may be blocking the inflammation, and we're just seeing progressive nervous system decline as part of the disease. So that needs to be kind of sorted out on an individual basis with the physician, but it could be one of those two possibilities.
Okay, thank you. And going forward, further along, can MS progress without showing any activity on an MRI?
Yes, MS can progress without showing activity on an MRI, usually in the progressive forms. Some people have relapses that are too small to pick up on the MRI, but more commonly, if somebody's having true relapses, we can see that on the MRI. But in progressive MS, we usually don't.
Thank you. So a person wants to know that if DMTs are for active SPMS, what does a person take if their MS is inactive?
Great question. So if you are under the age of 60 and have had a history of relapses, we might leave you on your disease-modifying therapy that covers relapses because relapses are still possible. If you are over the age of 60 and have not for 10 or more years had any changes on the MRI, but you continue to worsen, there's actually some ongoing research looking at what are the chances that somebody in that situation can come off from a disease-modifying therapy and move forward without more relapses. We don't have that data yet, but I've had this conversation with several of my patients, and some have elected to stay on their disease-modifying therapy and some have elected to come off. And we've just been watching folks in both situations. So again, very individual, but those are the principles that I use in my practice.
Great, thank you. So it was asked to Jeff about staying motivated, but this person wants me to ask you, how does she stay motivated during this time?
It's hard, isn't it? So one of my motivations is that my husband goes for walks with me. I'm tired. I work 8 to 10 hours. I come home, I do 4 more hours of work at my computer to finish my notes, answer emails, make sure I'm ready for the next day. I'm working 10 to 12 hours every single day. I'm tired too. I don't even have MS. And I know some of you do everything that I do and have MS. So it is hard with the fatigue to stay with it. So finding a partner who will go for a walk with you is really helpful. My husband will come for a walk with me. And if he doesn't come for a walk with me, we have all these like guilty phrases we give each other, right? Like, oh, so guess you want me to die an early death. Or we just have this sense of humor about it. So having an exercise partner can really be helpful. Giving yourself a reward, like Jeff mentioned earlier, not a cake, not something that's going to sabotage all of your efforts. But all right, if I go to the mailbox and back, even though I don't feel like it, then I get to listen to my favorite music or take a nap or watch my favorite show or not do the dishes tonight. So things that are a trade-off to self-reward. It's hard to stay motivated. And especially when you can't go out, you can't see your friends, but maybe have somebody who calls you and says, hey, did you go for your walk today? Did you get out and stretch? That can definitely help.
Great, thank you. What are the signs or signals that relapse remitting has switched to, they want to know about PPMS?
So relapsing remitting does not switch to PPMS. The PPMS means that you never had relapsing remitting in the first place. So let me just change the question just a smidgen and say, instead of we're going from relapsing remitting, we're going to secondary progressive MS, because that's how the definitions work. Sometimes it's hard and you can't tell when it first starts. So the definition that I've given, that many, not necessarily all MS specialists use, is there's been progression for a year without change in the MRI that both the patient and the physician can measure. That is a sign of progressive MS. But by definition, it's a year into it before you look back and say, oh, this is secondary progressive MS. So relapses that don't get better but don't get any worse are not progressive MS. A relapse that afterwards there's worsening of function, or no relapse and there's worsening of function, that is an indicator of secondary progressive MS.
Great, thank you for that. And okay, so what can you tell us about medications that are available these days for SPMS?
So the medications that are available these days for SPMS are all in the United States FDA approved for active secondary progressive MS. So when we look at, for example, Gilenya, or we look at Mayzent, or we look at Mavenclad, they are for secondary progressive MS with relapses. And the reason is that we've learned with many of these medications that are anti-inflammatory and decrease the immune system that they really help to preserve the nervous system from the relapses, but the secondary progressive seems to be a different phase. It's as though those nerves have already been damaged, the damage has already happened, and now they're just kind of pooping out and getting more and more fatigued. Or as we all age, our nervous systems start to shrink and we lose nerves. We have billions and billions of nerves. So if we miss, several thousand, we might not notice it. But in MS, that damages more nerves than would normally be damaged in the course of normal aging. And so as we get older and those nerves start to die off, there are more and more symptoms as well.
Great, thank you. I want to remind everybody that, yes, we have a lot of questions, but we're going to hold off on the COVID questions until towards the end, because heck, we have multiple sclerosis, right? We need answers about those things as well. So COVID is there, it is here. We will get to those questions. I'm just trying to, get through what we have here. We have a lot on different symptoms coming up as well. And in fact, I'm going to deviate a little bit and get away from the disease itself, and let's talk about some of the things to do with symptoms. So a person wants to know, do you describe LDN? And what are your thoughts about the swank diet or a plant-based diet for MS?
I have prescribed LDN. I'm not terribly impressed with it. I have used it as an adjunct complementary therapy. And in the patients that have used it, patients aren't real impressed. I'm not real impressed, but that doesn't mean that I'm, against it. I don't think it has really good data that it's actually addressing the disease. I think what it really does is it helps with some of the symptoms. So some people tell me that, their fatigue is a little bit less, or they have a little bit less pain and spasticity with the LDN. But it's an adjunct. I don't usually recommend it instead of modifying the disease, because that's really what in the long run has the benefit for patients, is trying to decrease that damage.
Great.
Plant-based diets are fantastic. They're part of wellness in MS. The swank diet is a very reasonable diet. Some people know about Terry Wall's diet for the MS diet. Any diet that really focuses on plants, lean meats, fish, green leafy vegetables, and olive oil, they all have different little spins on them, but that is a healthy diet and is absolutely the least inflammatory and the most likely to support the nervous system and the body moving forward.
Okay, thank you. All right, what can you tell us? What do you feel is the healthiest of all the diets?
It's probably the Mediterranean style diet. That's really the diet that slows down Alzheimer's, keeps Parkinson's from getting worse, that seems to result in the healthiest long life. It decreases the risk of certain cancers. It is just an incredibly healthy, reasonable diet. So maybe some combination of that with more heavy on the plants than on the meats.
Okay, thank you. All right, here's a different question. Thoughts on challenges of reaching out to patients with MS in rural America. How does this impact treatment for these patients with symptoms, problems, as well as the MS meds?
So this is a big problem right now, right? So we've got COVID. Even though we have telehealth, it's just not the same. It's not the same as being in the room with somebody. We go through so much training on picking up the thing that maybe the patient didn't even notice. So for example, when I'm looking at you through a screen, I can see you from your waist up, but if I'm sitting in the room with you, I can see that your left leg's kind of wiggling around and doing funny things. You might not have even noticed that. So we miss, as physicians, we miss some of the little subtle things going through a telecommunication. One of the challenges to telehealth in our area has been our broadband signal. The further remote somebody gets, they might be working on satellite broadband and they've got a weather cell going through the area and now I can't see anything. So that's been a huge challenge. Just the access to the office has been difficult. So some people, they're not in work, so they can't afford gas for their car, or they can't afford to get their car taken care of, or their friend isn't comfortable taking them to their doctor's appointments because everybody's got to wear masks and they either don't want to wear a mask or they don't mind wearing a mask, but they don't want to get sick. And so it's really been challenging. I was kind of joking with one of my physician friends the other day that it'd be really nice if we got paid to do house calls. We could just go around and do house calls at everybody's houses all the time. But unfortunately, that's a terrifically bad use of physicians. We cost a little too much to do that. And it is a challenge. So we've been encouraging patients to get in touch with us by phone and to email us with things if they can't get in to see us between visits. But I don't have any easy answers. It's a big problem.
Okay. All right, next one. My feet always burn. What can I do for this?
So the feet burning can be a lot of different things. The first thing that needs to happen is we need to establish that it is in fact from multiple sclerosis. And maybe in your situation, it was your first MS symptom, you've got a cord lesion, and that's all explained. But one of the things that I encourage patients is don't assume that every symptom you have is multiple sclerosis. So feet burning could be a sign of diabetes. You could have a low B12 level, or your thyroid could be off and you're actually getting nerve damage in the feet that isn't multiple sclerosis. You could have a pinched nerve in the back. So the first thing to do is to talk with your neurologist and find out where's this burning coming from. There are medications that decrease the sensation of burning, and those can be used. They're all off-label, not FDA approved unless you have diabetic neuropathy. Diabetic neuropathy responds to medicines like gabapentin, which is also called Neurontin, Lyrica, and Cymbalta, which is also called duloxetine. So there are a couple of different treatments. If you don't have easy access to medications, some people find that putting cool water on their feet helps. Some people find that squeezing the foot, so a firm sock can help, or compression hose help. Other people find, nope, 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 I don't want anything touching my feet, in which case you want to air them out and keep them from touching anything. So what tricks work depends person to person, but the absolute first thing to do is make certain you know why your feet are burning.
Okay, thank you. All right, so the next one is, can you shed any insights? Okay, we're not going to do that one. That's very difficult. So that's to do about people that are, why they're eliminating certain DMTs. All right, do you advise omega-3 fish oil?
There was some data that maybe, there was some data at first that omega-3 fish oil might help to remyelinate nerves, but repeat studies really haven't panned out. So I don't necessarily recommend the fish oils, but I do recommend eating fish, which will give you fish oils. And how much fish? About 3 servings of fish a week. And it needs to be a swimming ocean fish. So crabs don't count, lobsters don't count, and like catfish, probably not the best source of omega-3. You really want a swimming ocean fish to get that good omega-3 fatty acid.
Great. What can you tell us about the leaky gut?
I can't tell you much about the leaky gut. And the main reason is that I watched the research on it, but it isn't an established science, in my opinion, and we haven't really figured out what to do with it. Should everybody be on probiotics? Should we be doing fecal transplants? What should we be doing with that? I think the best thing that you can do is feed your gut healthy foods to really make it as healthy as possible. So the gut is where the immune system really is the most active. And if the immune system is constantly being pounded with chemicals and preservatives and fast food and restaurant food and boxed food and microwaved food, the immune system is constantly arguing with and fighting with all of these chemicals, and really trying to flush your system out with the more healthy, plant-based, Mediterranean-style diet foods that are naturally made to absorb in the gut really ought to help with a leaky gut, should help with an immune system that's out of whack, should help with that inflammation. And so again, going back to the diet.
Great, thank you. All right, so would an occupational therapist help me to find better ways to do things in my home?
Occupational therapists are really good at that. So occupational therapists are the people that you go to if you've got issues with the arms or with using your environment. The physical therapists are really fantastic with gait and mobility issues, and they've kind of divided up their work that way. So occupational therapists can be helpful to come into the home and have you do things this way instead of this way. Now, in order to get an occupational therapist to come into the home, though, you have to be eligible for home health. So if you are out and about, you can go grocery shopping and visit your friends. I know maybe not with COVID, but if you're ambulatory and can get around, you might not be eligible for an occupational therapist to come into the home, but you could get a referral from your doctor to go and describe some scenarios to the occupational therapist to help you make some modifications.
Okay, thank you. All right, what can you do to help with spasticity? I know Jeff covered this, but maybe you can add a little bit more.
One of the best things are stretches that are designed for you by a therapist who understands your body mechanics. Massage helps tremendously. All of the medications that we use aren't really specifically for spasticity. So even baclofen, tizanidine, Flexeril, cyclobenzaprine, the muscle relaxers and the antispasmodics can sometimes be used. But for those of you who are on these medications, you know they can cause a lot of dry mouth, and they can cause a lot of sleepiness, fatigue, and sometimes memory problems. So they're not fantastic medications. If the spasticity is really bad, we can use Botox to loosen the muscles so the limb is not as spastic. Some people get implanted into their spine a baclofen pump, which goes right into the spinal cord and relaxes those nerves right in the spinal cord. So those are all things that can be used. And some people have less severe spasticity and might be able to do massage and exercises. And some people are more severe and may need braces and baclofen pumps and Botox.
Okay, thank you for that. Let's see, another person writes, all right, let's do some COVID questions, okay? Because there's too many COVID questions now. All right, so this one writes, how do you think that COVID is affecting minorities with MS?
You know, the data on this is really tragic. So minorities, essentially non-Europeans, are really being devastated by this disease. The death rate is much higher. The hospital admission rate is much higher, especially in people of African descent, and people of Hispanic descent are really having a hard time with this virus. And we don't know, is that socioeconomic differences? Is it access to care differences? That certainly could be playing a role. Are there genetic differences? Are there We know there are blood type differences. So people with O positive blood tend to do better than people who don't have O positive blood. Why is that? And men tend to be twice as likely to be affected by the ill effects of COVID as women. Does that mean we just lock up all the men and let the women out? I doubt that's the answer either, but there is just a lot of really interesting data that's coming to the forefront here. But unfortunately, especially minority men, this is not, they're the ones that are getting disproportionately affected. So when I say that there's a 2 to 3% death rate, it's higher in minorities and it's higher in men than it is in women.
Okay, thank you for that. Now, the next one is, I was diagnosed in 1993. I've never taken any of the DMTs and have done very well. Am I at a higher risk of COVID-19 than the general population?
Well, unless I calculate your age to be over 60, no, you're not. And even if you are over 60, your age, the MS doesn't change your risk any more than any other person over the age of 60. So no, especially if you're doing well, you're mobile, you don't have a compromised immune system from medications, then nope, the MS does not change your risk.
Thank you. Sorry, I cut it off short. This person also continued with saying, I'm 57, I carry a few extra pounds, and I follow all precautions.
Got it. You're at pretty low risk. If you are following precautions, then you're at pretty low risk. You're under 60. If your BMI is over 30, then you're at higher risk. If it's under 30, you can have a couple extra pounds as long as your BMI is in that 25 to 30 range. You don't have that dramatically increased risk.
Great, thank you. And then we have, I've been on Ocrevus since it was approved after reading the latest news on how it diminishes the flu, pneumonia, and chickenpox vaccines. Do you recommend it?
I do recommend it. And part of the reason that I recommend it is it is a fantastic medication. It is incredibly good at modifying the course of multiple sclerosis, and everything in treating in medicine is pros and cons. So if you are a person who is on Ocrevus and you get your boosters for the shots in that 2 to 6 week window, you're going to maximize those injections, those vaccines. When the COVID vaccine comes out, if the COVID vaccine comes out, when the COVID vaccine comes out, you still want to use that kind of a window so that your immune system can make its own memory of the vaccine. Ocrevus isn't taking out all of the B cells, the antibody cells in the whole body, but it does take out those that are circulating. So you still have cells in your bone marrow that can remember that vaccine and can pop out if you are exposed to anything you've been vaccinated against. You're correct, the medication decreases how well your body responds, but it doesn't entirely eliminate those vaccines and those vaccine memories. So I think that in people who have significant enough disease where the disease of the MS is particularly dangerous, Ocrevus is an excellent choice, even balancing against the fact that it may be decreasing those vaccines.
Okay, great, thank you. All right, so the next one is similar to what was before, but are there greater portions of the United States that COVID-19 is more greatly affecting the minority population?
My understanding of reading the data is that the minority population is more affected everywhere that COVID has struck. So in an area where there are a lot more minorities, you might see higher death rates because there are more minorities, but that doesn't necessarily mean that if those minorities lived in North Dakota, that they would be at any more or less risk. What we're really measuring is the risk of that minority population. What seems to be happening, and this was predicted at the very beginning by medical professionals, was that the COVID kind of comes through an area, it spikes, it gets real hot for a while, people start wearing masks, the medical community dampens it down, enough people now have gotten it that we're not spreading it as much, and then it quiets down, and then somebody from that hotspot area goes and travels and you get a hotspot over here, and then that quiets down. And so we're going to see these hotspots piping up all over the place. First it was Seattle, then New York, and Florida just went through a spike. My area is going through a spike right now. Michigan was really low for a while and then started to spike up. So this is a virus that's going to do that, and it's probably going to continue to have spikes and hot spots and up and down until we figure out how to eliminate it or how to manage it to the point where we don't have to worry about these hot spots. But for now, it keeps flaring up and calming back down. You can kind of think about it as the virus equivalent of multiple sclerosis, right? Just shows up in some random place, causes all kinds of havoc, and then calms down a little bit.
Right. Thank you for that. What is the overall impact of COVID on multiple sclerosis?
The overall impact, fortunately, does not seem to be particularly different than in the non-multiple sclerosis population, which is really good. We're not seeing, huge, devastating, different complications in multiple sclerosis patients. Where I am seeing a difference, though, is that my MS patients can't get to their resources. So their gyms are closed or their exercise classes aren't going on. And so I'm seeing a lot of backsliding in mobility because people aren't able to access those resources. And this is where, of course, I have a struggle. I mean, at some point, how do we measure what's the risk of the virus versus the risk of all staying home? And that's harder to measure scientifically. It's harder to measure from a medical standpoint. If somebody dies from COVID, we can measure that, we can count that. But if somebody, goes from using a walker to having to use a wheelchair because they couldn't get to their exercise program, that's a little bit harder to measure. And I do worry about the long-term effects of that on the MS community, just not being able to get out and keep the bodies moving and healthy.
Okay, thank you for that. Person writes, how bad is COVID-19 at present in the USA? Is it getting better or worse? I need to know if it's safe for me to go to the grocery store with a mask on and do errands for my parents and myself. I'm at this time not on a DMV, just MitoQ.
Okay, so going to the grocery store is a pretty low risk activity. So wear a mask the whole time you're in the store. When you get home, wash your hands after you put away your groceries and wash your mask 2 times a week. Don't use the same mask 2 days in a row because it can be collecting COVID. We're not hearing a whole lot of people self-infecting with the mask, so I don't think you need to be any more worried about it than that. Wearing gloves does not help. Washing your hands helps. Staying away from people who don't have masks on, that helps. If you live in a state like I do, where masks are mandated indoors, it's much easier. But I know in some places they're not mandated indoors, and you might go into a crowded grocery store and you're the only one wearing a mask. Get in, get out quickly if you have to, or come back when it's less busy. Many stores around me, and I've noticed some of my friends have talked about in their areas as well, have specific shopping for people who are senior citizens. Well, senior citizens that's a pretty vague term. If you're over the age of 55, you can be considered a senior citizen. And the idea is that the people who are at higher risk of COVID would be able to come in at a lower volume time and go shopping. And I would definitely take advantage of that if you are of the age. So those are some ways that you can get around it. How much is your risk if you're following those principles that I outlined before? Fortunately, very small. It's a very small risk.
So I have a good one here that I have never had anybody ask any of the doctors that we've had online before, and I think it's a great question. K95 or fabric?
Depends on what you're going to do. All right, so a K95, NK95, or that is the mask that we use in the hospital. It has a tight fit. It goes around the nose so that there's no gaps, and the fabric is very tight so that it blocks 95% of particles from going through it, right? A fabric mask, a 2 or 3 layer fabric mask, isn't quite, but is almost as good as an NK95 mask. So if you can't afford a box of NK95s, or like at the beginning of the pandemic, we couldn't even in our medical office get a hold of them, the fabric mask protects other people more than it protects you. the NK95 protects you better than, actually, as well as it protects other people. So that's really how you sort that out. So I'll give you an example. We had a family tragedy in about middle of July, and I actually unfortunately had to fly to Florida right as they were starting their spike, and I was not excited about flying, and I was not excited about flying to Florida while this spike was going on. And I wore an NK95 mask all the way to Florida, washed my clothes, took a shower when I got there, went to my uncle's house where he passed away, not from COVID, wore my NK95 there just in case I brought something in, left, went back to my hotel, washed up, put on my mask before I went to the airport again, and I wore that NK95 the whole time. So that's a situation where I would wear an NK95. When I go to the grocery store, though, I use just the regular surgical masks. I don't use anything particularly special. Why? Well, because I'm not sitting right next to somebody else that I don't know who might be sick for a long period of time. I'm not in somebody's house very close to them for a long period of time. I'm not in my office where I'm talking to patients face to face. I don't use an NK95 in my office, but I use a mask that was made specifically out of sterilization paper that they use in the operating rooms that is also of a similar filtration as NK95. They're cheaper because I had more of them made. So that's a situation where I might recommend an NK95, or if you're going to be around people for a long time. But otherwise, that 2-ply fabric mask actually works pretty decently at preventing you from spraying COVID onto somebody else, but does not necessarily protect you very well.
I have a different mask for every outfit I wear. People think I'm insane, but and I have so many different K95s. It's the USA ones can almost suffocate you compared with the Chinese ones. So.
And you know what? That's one of the complaints I have about a K95 is they are very hard to breathe through for a long time.
Extremely. Especially in the heat down here in Florida. So, you could just walk out to your car and it's like, or just come out of a building and like, you can't wait to get this thing off so you can take a breath of air.
Yep.
So,
yep.
Okay, so we have a few questions now that, I'm going to go back now and hit on just a couple. We only have a few questions left, but I want to get away from COVID for a minute and get to these other ones. So, has research found a cause for MS?
I think there are so many causes for MS. What we're really measuring is the immune system's response to we don't know what attacking the nervous system. And whatever the we don't know what is may be long gone. So it's been known for years that people with MS are more likely to have been infected with Epstein-Barr virus. Not everybody with MS, so that's not everybody's trigger. But is there something about Epstein-Barr that if you have a particular immune pattern or your particular genetics or other factors are present at the same time, you're low in vitamin D, you're overtired, you had a car accident, you had your gallbladder taken out, and you got Epstein-Barr, bam, your immune system goes crazy and starts to attack. Well, your immune system can clear Epstein-Barr in many cases, and it may be long gone. So treating you for Epstein-Barr is beside the point. We do know that vitamin D deficiency allows the immune system to attack the nervous system, and the nervous system isn't as well protected. And once you fix the vitamin D problem, though, that doesn't fix and cure the multiple sclerosis. It may make your body less susceptible to the attack from the immune system, but it doesn't go away. So in summary, the medical research really shows that there probably isn't one cause. It's many different causes, and in one person, it might be 4 or 5 different causes in that person that finally resulted in the immune system going haywire. Once the immune system's haywire, though, the original cause might not be fixable because you've already gone down. It's the end of a chain reaction, and you've already suffered some of the damage at that point.
Thank you. All right, now here comes another one that's probably, well, it affects thousands, all right, hundreds of thousands. Who can help you if you're all alone?
Yeah, that is really hard. If you don't have a support network, even those of us with really good support networks are struggling right now with COVID. Some examples of folks that might be able to help. local resources like food pantries, Meals on Wheels, if you are eligible for local social work services, or your insurance might send a case manager to make phone calls to you. That would be a potential resource. Some of my patients reach out. We're in an area where a lot of people go to church, and so they reach out to their churches. Some people are in areas where they have a lot of social Kiwanis Club, or they have the Elks Club, or they've got lots of social resources, and they can reach out and say, hey, I need help with this, or is there anybody who is volunteering to do this? So unfortunately, the biggest problem is that the resources aren't real great at searching you out, and that's really what would be ideal. But picking up the phone and making phone calls and trying to find out what your network is really the way it goes. And when you don't have a lot of resources, it can feel sort of alienating even to do that. So again, I don't have any great easy answers, but I can tell you some of the ways that some of my patients have reached out and been able to find people to help them and come around them. Sometimes you'll be surprised. Maybe you've got a neighbor in your apartment building or right next door who's bored out of their minds and would love to make an extra serving of dinner and put it on your porch. Who knows? So asking is really, really important.
Thank you. All right, 2 questions remain. First one, my exercise routine involves a gym, pool for swimming, laps, and hydro classes. Due to COVID-19, this is no longer available. What do I do? And I'll say she or he probably doesn't have a deep enough tub.
Probably not, and you probably don't have the budget to put a pool in your backyard either. This is definitely a challenge, and I can't force them to open the pools, and I also can't make the pool a safe place for everybody to go, right? So part of the reason that people are closing things down is that if a whole bunch of people went to the pool and they got sick, there would be the possibility that you could sue the people that own the pool because you got sick, and it's all, the whole thing's a mess. The whole thing's a mess. This COVID has just messed up everything. Water therapy is fantastic because it takes the pressure off from your joints, and you can do more exercise in the water if you're a swimmer than you can on land, and that's all very, very true. If this were normal times and there was something wrong with your pool, I might say, well, try a rowing machine. But unless you happen to have a rowing machine around, that's not necessarily going to help. Why a rowing machine? Well, because there's not a lot of up down, and some newer rowing machines actually use water action to work against you, so you get a similar workout to being around water. But some people don't have that resource. If you don't have a pool, you can use weights, you can use TheraBands. If you've ever seen physical therapy, you know that there are different strengths of bands. If you haven't ever seen physical therapy, but you want to go on Amazon and buy a band, buy one of the lowest tension bands, because the lower tension still gives you a workout, but it doesn't fight you as much. It doesn't give you as much tension, and you can get a lot of those movements in that you would do while you're exercising. You can just take the band and move it out. You can do the same thing with your legs and just try to keep active that way. That would probably be one of the least expensive, simple ways to keep up with the exercise if you don't have access to your pool.
Okay, great. I had thought that it was 2 remaining. It was only that 1 remaining. So I'm going to say thank you for everything you did. And I want to thank everybody that was online with us this evening. And please know that in about 1 week from now, this will all be on our YouTube channel. So you can come back, you can watch it again and again, you could share it with others. Dr. Cramer, I hope that you can also share it with your patients, let them know about that fantastic resource called the MS Views and News Learning Channel on YouTube, okay? And where there are over 500 videos to choose from and watch and learn from, not just about COVID, not just about what you may have heard tonight, but anything and everything about multiple sclerosis can be found on our YouTube channel. And so again, I want to thank Novartis for supporting tonight's program, and I want to thank Dr. Cramer again for being here, and I'm going to say good night, world. Have a good one.
Thank you.
Thank you.